a little bit to the left. So you get a slight left axis deviation when you lie down, and when you stand back up, it moves slightly back to the right, so you get slight right axis deviation when you stand up. And it also can change physiologically in inspiration and expiration for similar reasons, just with the lungs moving the heart. So this is just a simple illustration of how it would look on an X-ray pathologically if you compare normal left and right axis deviation. However, that will be covered by the next lecture, not particularly by me. So just a quick knowledge check. So I think we need to launch the poll for this one. So I'm just going to launch that, and you guys should now be able to quickly vote on what you think the answer is to where does electrode V2 go. Great. Perfect. I'm going to end polling because most people seem to be getting it right. And share results so you guys can see that. Perfect. Great. So yes, the answer was C, the fourth intercostal space at the left sternal edge. So there'll be a few of these little knowledge checks at various points, so make sure you're listening. What does it all mean? So what does each wave on an ECG mean? I think this is really, really helpful to be able to understand the pathology, and also to be able to, like if a consultant hands you an ECG, for you to be able to read it and understand what might be wrong, even if you can't, even if you don't have every pathology memorized, if you kind of understand what each wave on an ECG means, that's a pretty helpful start. So this is a nice representation of everything, which we'll come back to. But what I've used to talk about it is this more simple illustration. So we're going to go through what each wave means. So first of all, we've got P waves. So this is the P wave, and the P wave represents atrial depolarization. So in healthy individuals, there should be a P wave before each QRS complex. And as will be covered in the pathology lecture, this can be changed in certain pathologies. So for example, in atrial fibrillation, you don't have any P waves at all. And you can sometimes get strange shaped P waves, such as P pulmonale and P mitrale. I'm just gonna, oh, okay. There seem to be a lot of people that have missed the start, it says in the chat. There wasn't too much at the start. I can go back over it at the end if people want me to. Okay, so the PR interval. So what you need to remember about intervals is that they always start at the beginning of a wave. Completely missed all of it so far. Oh no. Hinal, is there some kind of issue with the Zoom getting to people? Do I need to start again? Right, right. Missed the whole start. Okay, I'm going to start again, guys. It appears that everyone has missed the majority of what was going on. So I will just restart. Okay. So it appears that the Facebook Live was, but not the Zoom. Okay, let's go back again. Okay, back to leads and electrodes then. Okay, I'll start all over again. So an ECG lead is a graphical representation of the heart's electrical activity, and that's calculated by analysing data from several different electrodes. How long will the session run? It won't be too long, don't worry. A 12-lead ECG records 12 leads, and that produces the 12 separate graphs on a piece of ECG paper. But however, only 10 physical electrodes are attached to the patient to generate the 12 leads. So it's quite confusing, but what you need to remember is that leads do not equal electrodes. Okay, so what I mentioned here earlier was that you need to think about ECGs in terms of electrical potential and changes in the electrical potential of the heart. So the 12-lead ECG is derived as a means of 10 different electrodes. Three of these leads are quite easy to understand, so they're just the comparison of electrical potentials from 2 electrodes, one being the exploring and one being the reference. But in the remaining 9 leads, the exploring is just 1, and the reference is obtained by combining 2 or 3. So someone's just asked, have I missed a lot? And I've only just got added. I've just started again because that happened to a lot of people, so don't worry, we're right at the beginning. Okay. Okay, so what's the electrode? The electrode is the conductive pad that's attached to the skin to record the electrical activity. And the data gathered from these electrodes allows the 12 leads of the ECG to be calculated. For example, lead 1 is calculated using the data from the electrodes on both the right and the left arm. So I go over that in a bit more detail later. And the electrodes are used to generate this 12-lead ECG that we talked about. I think someone asked if you can have a 6-lead ECG, and I believe you can, yeah. Okay, so this was just me talking quickly through where the electrode placement would go, especially on the chest. So in an OSCE station, for example, you might be asked to put the electrodes onto a person, and you would kind of need to know where exactly everything would go. So firstly, you've got V1, which is the first chest lead, that goes on the 4th intercostal space at the right sternal edge. Then you've got V2, which goes on the 4th intercostal space, but the left sternal edge. Then I like to go to V4, which is at the 5th intercostal space in the mid-clavicular line. And then you've got V3, which is midway between those two. And then if you think about V5 and 6 as being on the same horizontal line as V4, these two, so V5 is on the left anterior axillary line, and V6 is on the left mid-axillary line. So that's the chest leads, but what do they actually show? So the chest leads show different views of the heart. So V1 and 2 is septal, V3 and 4 is anterior, and V5 and 6 is lateral. So I have an acronym for that, which we will cover in a couple of slides' time. Then you've got 4 limb electrodes. So you can think about these with the acronym Ride Your Green Bike, which is quite useful. So that's Ride Your Green Bike. I'm hoping you can see my mouse moving right now, but that's right arm, then left leg, then right leg is how you'd remember. And these are usually on bony prominences such as the ulnar styloid processes and the medial or lateral malleolus on the legs. Okay, and what do those actually represent? So lead 1 and AVR and AVL represent the lateral view. Lead 2, 3 and AVF represent the inferior view. And as I said, I'll go through the acronym in a minute. But this also shows what we were talking about before with having the exploring and reference electrodes. Do the ones on the leg go on the medial or lateral malleola? Yeah, they can go on either, it doesn't matter. And then AVR, AVL, AVF, these are the ones where I mentioned sometimes you use 2 or 3 electrodes to calculate the reference, with the exploring still just being 1. Okay, and then this is how an ECG trace would be given to you and how you'd be sort of asked to interpret it if you were given one. So what you get is all of the leads on this one page. And why this is helpful is because it can help you to localize some of the pathology. So for example, if you have a myocardial infarction or a heart attack, you can tell which area it is in by looking at where the particular changes are on the ECG. So for example, it could be anterior, it could be inferior. And so that can also help you sometimes deduce which particular coronary artery is infarcted, for example, is affected, sorry. And then this is an easier way of thinking about that. So that's an easier visual representation of the previous picture. And then this is another way of remembering it if tables work better for you. But this is the way I like to use. So this is the acronym down at the bottom here. So that's SALI. So septal, anterior, lateral, and inferior. So septal being V1 and 2, anterior being V2, V3 and 4, lateral being V5, V6, 1 and AVL, and inferior being 2, 3 and AVF. That should be AVF, not IVF. Someone's just asked, why do you get changes in certain parts of the ECG? So if I just go back for you. So why would you get changes in certain parts of the ECG? So for example, if the heart muscle is damaged, it's not going to contract properly. So that's what would happen in a myocardial infarction. So you'll get changes. So I think most of you missed the beginning where I mentioned that this lecture doesn't go that much into pathology. This is how to read an ECG. And it's like the very basics, and there'll be another lecture that covers pathology specifically. But for example, in a myocardial infarction or a heart attack, you're going to have what's called ST elevation, and we'll talk about the ST segment in a little bit more detail later. But so for example, if in the anterior part of the heart you have a myocardial infarction, that part of the heart wouldn't contract properly, therefore there'd be changes in the ECG that you could see, such as those ST elevations in the ST segment, or sometimes you get things called inverted T waves, etc. So I hope that helps. I'm going to carry on. So I explained the acronym, and then I left this image up here because it illustrates the point I was talking about before in terms of the fact that you can kind of localize the pathology to a specific area or a specific coronary artery. Okay, so now we're just going to quickly go over Einthoven's triangle. So this is an imaginary formation of the 3 limb leads in a triangle, which is used for ECGs. Someone's just asked me what a blood culture is. I'm not sure that's relevant to ECGs, but I'll answer at the end if I have time. So this triangle is formed by the 2 shoulders and the pubis, but those are imaginary points because technically you're actually using the limb electrodes. And the resultant vector is called the QRS axis, and it approximates the mean electrical axis of the heart. So the mean electrical axis represents the sum of all of the mean electrical vectors occurring during ventricular depolarization. So you might be like, this sounds really complicated, why is she talking about physics? But what do you actually need to know from this? You need to know that the mean electrical axis of the heart normally lies between -30 and +90. So that is the normal range. And this can change in a number of both cardiac and physiological conditions. So less than -30 would be termed a left axis deviation, so that's in this segment, and greater than +90 would be termed a right axis deviation. So that can happen in all kinds of pathologies, for example, in hypertrophies, where the heart muscle becomes like thicker, for example, and therefore would contract harder on one particular side than the other, and therefore the axis would deviate. But it can also change in physiology, for example, just between lying down and standing up. So lying down, for example, you have slight left axis deviation. Standing up, you get a slight right axis deviation. And it's the same with inspiration and expiration because the lungs compress the heart and move it around inside. Okay, so this is just quickly showing kind of what the difference would be on an ECG, although this will be covered by the other lecture, not particularly by me. There is a way to remember this it's called like leaving and reaching, but I'm sure they'll talk about that. But it's here if you want to have a look at it. Cool. So just a quick knowledge check. We did a poll before. I think most people were here for the poll. Can I get some kind of indication if people already did the poll? People seem to be putting their hands up, so yeah, okay. So I'll skip that question as it seems most people did the poll. So let me go back to this. I think someone said, oh, someone said they didn't do the poll. Okay, well, the poll was just asking, I'll go back to it, just asking where does electrode V2 go? And the answer was C, the 4th intercostal space at the left sternal edge. But there will be more SBAs, so don't worry about having missed out on that one. So someone asked if I can come back to this one. I will be coming back to this one because I need to use it to talk about certain intervals, so don't worry. But the one I'm going to use to talk about the actual waves is this one because it's much simpler and easier to explain with. So what is a P wave? I think this is where people started coming in, where I started talking about P waves. So the P wave is this little bump here before the QRS complex, and it represents atrial depolarization. So in healthy individuals, there should be a normal QRS complex, and that should be before each normal P wave before each QRS complex. Sorry, someone's just asked if I can go over Sally again. Okay, sure, let me go back and do that. So this is Sally, septal anterior lateral inferior with the letters highlighted. So V1 and V2 here, V3 and V4, V5, V6, 1 and AVL, and then 2, 3 and AVF. You can find this acronym online as well, so don't worry about just type in Sally and ECG and it'll come up. Okay, so P waves represent atrial depolarization. In healthy individuals, there should be a P wave before each QRS complex, and as will be described probably in the pathology lecture, sometimes you don't have P waves, so that can occur in atrial fibrillation, and sometimes you can have strange shaped P waves. So for example, there are conditions, so there's P waves called P pulmonale and P mitrale, which occur in different atrial hypertrophies, but this is what a normal P wave should look like. Okay, then we've got the PR interval. So the PR interval starts at the beginning of the P wave and ends at the beginning of the Q wave. So when you have something that is talking about an interval on an ECG, you have to always remember that it starts from the beginning of a wave usually. And the PR interval specifically represents the time taken for electrical activity to move between the atria and the ventricles. So that's between the sinoatrial node and between the atrioventricular node. Cool. The QRS complex represents the depolarization of the ventricles. So this appears as the three closely related waves that you see here. So the Q, the R, and the S. And that I will talk about later, but that should be a specific length and it can't be too long because that's pathological as well. And then we've got the ST segment, which I mentioned a little bit before. So segments are not the same as intervals. So intervals, as I mentioned, start from the beginning of a wave and end at the beginning of a wave, but segments don't necessarily start at the beginning. So this ST segment starts at the end of the S wave, so here, and ends at the beginning of the T wave. And the ST segment is simply an isoelectric line, so that means that it's like the baseline electrical potential that represents the time between the depolarization of the ventricles and the repolarization. So it represents the time during which the ventricles are basically contracting. Then we've got the T wave, which is after the QRS complex and represents ventricular repolarization. Great, and then this is where I said I'd go back to the other diagram. So the RR interval, let's go back and look at that other one because it has the RR interval a bit better. So this is the RR interval. So as you can see, this is one R wave and this is the next potential's R wave. So that is what you call the RR interval, and as we'll talk about a bit later, that's quite useful when it comes to calculating rate. So the RR interval begins at the peak of one R wave and ends at the peak of the next, as we mentioned, and it represents the time between two QRS complexes. And then we've got the QT interval, which begins at the start of the QRS complex and finishes at the end of the T wave. So that's all of this time taken here, and it represents the time taken for the ventricles to depolarize, so the QRS complex, and then also to repolarize, so the T wave. Okay, so we've got another SBA, so that's poll number 2. I'll just launch that quickly. So what does the P wave represent? Oh I'll give you like 15 seconds or something to vote on that. Oh, amazing. I don't think you even need that long. Okay, I'll just end polling now. Perfect. So almost everyone got that. It is atrial depolarization. Well done. Okay, perfect. When measuring, do you have to use the RR interval? So I'll talk about measuring rate in a minute. Great, so strategy for reading ECGs. So what I prefer to use is what I call the 6-question or the 6-point strategy. And this is how I was taught to read ECGs, and I think it really, really simplifies the process. And I think, so for example, if someone hands you an ECG and goes, interpret it, if you can ask yourself these 6 questions, it makes the process a lot easier and a lot more harrowing, because you have a formula in your head to work from. So first of all, what you're going to ask yourself, what is the heart rate? And you can look at the RR intervals, but there are other ways of calculating rate, which I will mention. Then you're going to ask yourself, what is the heart rhythm? Is it regular or is it irregular? And then you're going to ask yourself whether you can see a P wave, and is there one P wave before each QRS complex? And is that P wave of normal duration and also normal shape and morphology, as we mentioned before? Then we've got, is the PR interval of a normal duration? Is the QRS complex a normal duration? And is the ST interval elevated or depressed? Is the QT interval normal? And is the T wave inverted? So I'm just going to go through these one by one now. So first off, we've got the rate. So there are a few ways to calculate the rate. So as mentioned before, using the RR interval. So what you would do is to take the distance to the next one. So you'd count the number of large squares between them, and then you'd do 300 divided by the number of large squares between 2 R waves. And then the other way to do it is, usually at the bottom of an ECG, there is a rhythm strip, which you can use to calculate rate, because that tends to be 10 seconds. So this is like the biggest ECG hack that I learned, is like in real life. It's obviously, if you're in a spotter exam, they're not going to give you that rhythm strip, and you need to know the ways of doing it properly from the RR interval. But in real life, you'd look at this base strip, which has 10 seconds worth. So you can count the number of QRS complexes in that 10 seconds, times it by 6, and that will give you the number of beats per minute. Someone's just asked, should you always measure the height of Q waves, QRS, and P waves? No, not really. The height sometimes matters, which will be talked about in the pathology lecture, but you don't really need to measure it every time you're looking at an ECG. Okay, so rhythm, how would you look at rhythm? So this is quite an obviously abnormal ECG. So what we would look at is whether these RR intervals that we measured before are the same or whether they're different. So as you can see, this RR interval between these 2 peaks here is much, much shorter than the interval between these 2 peaks here. So we can say that this is an abnormal rhythm, and also that variable RR intervals tend to indicate some kind of heart block or pathology, though the specifics of that will be in the pathology lecture, not this one. Okay, and then, so this is just a quick knowledge check. It's not on a poll. I'll just kind of talk through it, but I'm not sure how well you can see the boxes. I'm aware they're a bit blurry, but how would we calculate the rate from this one? So we would take the number of big squares. So I know it's blurry, but you can take my word that there are 1, 2, 3, 4, basically 5 large squares between the 2 R peaks. And you would then do 300 divided by 5. So someone's just said, is it about 60? And yeah, exactly. So 300 divided by 5, you get 60. Perfect. So that's how you'd calculate the rate from that one. And then we've got this one. So this is another quick knowledge check. So would you say that the rhythm here is normal or abnormal, just type in the chat and we'll see what the overall opinion is. Yeah. Yeah, so everyone seems to be saying abnormal or irregular, which, yeah, great. So this is obviously abnormal because we've got the variable RR intervals as we mentioned before. Perfect. Okay, and now going on to the actual durations of how long each of these waves was supposed to be. Someone's just asked what was the hack for rate again. Okay, I'm going to go back to one of my earlier ECGs and try and show you the hack instead of describing it. So here, if we use this one, for example, yeah, so if we use this one, for example, you can use this strip at the bottom. So usually standard ECG means that this is like recorded over 10 seconds. So you can just count the number of peaks here, times it by 6, and then that would give you the number of beats per minute. I think some other people had some questions, which I'll just quickly answer before I carry on as well. So what did people say? So in this, you would count and times by 6 and not do the other method. So if you have an irregular rhythm, you cannot calculate the rate using the RR interval method, but you would never be asked, like in a med school question, to calculate the rate of a irregular ECG. Where did the 300 come from when 300 over 5 happened? It didn't come from anywhere. It's just that's just like a standard rule. So that's just the way you do it. That's just how it's calculated. It's always 300 divided by the number of large squares. I don't know why. If anyone else knows, feel free to like say. But yeah, okay. So P wave should be no more than 2 small squares long. So this isn't big squares, it's small squares. So no more than about 80 milliseconds. And as I mentioned before, you can also get oddly shaped P waves. So that's what we call the morphology of the wave. Then you've got the PR interval, which should be around 120 to 200 milliseconds. And any greater than this would indicate some kind of heart block, so slow conduction through the AV node. Someone's just said, is this lecture aimed at 5th years? I would probably say no, because this is like very, very basic. And as I mentioned, there's like another pathology lecture which will go over like specifics of pathology, which would probably be more useful to 5th years. But stick around if you want to. Okay, so yeah, so heart block, which is slow conduction through the AV node. QRS duration. So the QRS complex can be taken as an indicator or a proxy for synchronization, and it should be less than 120 milliseconds. So if it's any longer than 120 milliseconds, basically what you can conclude is that ventricular depolarization is slow, or that part of the heart muscle is not contracting normally. And then finally, you've got ST, QT, and T. So the ST interval should be at baseline, should be a straight line, shouldn't have elevation, which is for infarctions, or depression, which is usually for ischemia. But that, again, should be covered. And then you've got the QT interval. Oh dear, what did I do? The QT interval, which is dependent on the heart rate. I hope no one saw the answer to that, but I'm sure you did. So you'd look at the corrected QT interval, which corrects for the heart rate. Okay, so you might have seen the answer, but you can answer the poll anyway. What is the normal PR interval? How interesting. Okay, I'm going to end polling and share results there. So most people tended to go for C, with quite a lot of people surprisingly going for E. So the normal PR interval is C. It's 100 to 120 milliseconds, not 140 to 200. That would be far too long. And this is the next one. So what is a normal cardiac axis? So let me stop sharing results and start the next one. There you go. What's a normal cardiac axis? This was quite a while ago, so hopefully you remember. Great. So overwhelming majority said C, minus 30 to plus 90, which is correct. Well done. And I have finally got a few case studies for you. So someone said, I thought it was 0.2 to 0.2. So I said on the slide it's 120 to 200 milliseconds. Wait, did I type the question wrong? Yeah, I did. My bad, guys. The question was wrong. Whoever spotted that, well done. Okay. So a number of, just a couple of case studies really quickly. So if we just work through this ECG using the principles that we've been through. So firstly, having a look at the rate and whether we think that's normal. So if you just have a look at how many large squares there are, so about 3 and a bit, so 300 divided by that would be just under 100, which you could say is probably a little bit high, but probably normal. And then we'd look at the RR interval. So the RR interval appears to be the same. So we could say that the rhythm is normal. Can we see P waves? Yes, there are P waves here, there are P waves here, there are normal looking P waves everywhere, and they don't appear to be too long or have an abnormal morphology at all. And then the QRS complex, it appears to be of normal duration, so we can count the small squares and conclude that it is a small, that it is within the correct limits. And then finally, is the ST segment elevated or depressed anywhere? Not really, it's quite normal as you can see throughout. Is the QT interval normal? We have to correct for the heart rate. And are there any inverted T waves? So are there any upside down T waves? Which no, not really, there aren't. So from that, you can tell that this is a normal ECG. And then we've got a very quick, not normal ECG. I'll tell you that much. Should you actually actively check for Q waves in each lead? And how big should these be to be significant? So that will be covered in the pathology lecture, as I talked about. There are things called pathological Q waves, which are basically just really big Q waves. And there's a way to define it, which is like, it has to be, I think it's more than 2/3 the size of the P wave or something like that. But that will definitely be in the pathology lecture, not in this one. So this case study is a very abnormal one. So as you can see, the RR intervals are variable. So this is not a regular rhythm. So I wouldn't go to like try and calculate the rate for this one because it's abnormal. And then you can have a look at the P waves. So are there P waves? Yes, sort of, kind of in some places. Is the PR interval normal-ish? Is the QR interval normal? QRS complex normal? It's possibly a little bit broad, but not too bad. And then the major issue with this is that there is ST elevation, and this is actually an inferior STEMI. So you might have spotted you've got ST elevation here, for example. And then you could check the QT interval and any inverted T waves as well. So inverted T waves would also signify pathology. So that's what exactly was on here. So type 1 AV block, which is why we had the variable rhythm. And yep, so sometimes when you have an MI, which is an ST elevation MI, you can also have reciprocal ST depression. But again, that should be in the pathology lecture. Someone's asked, when is the pathology lecture? I'm sure Hinal from Becoming a Doctor will tell you that at the end, because I don't know. That's not by me. So the main takeaway messages, as I mentioned, this lecture would be quite short because it was very, very basic, and the next one should be more in-depth in terms of pathologies. So remember the 6-question strategy, so rate, rhythm, P waves, PR interval, QRS complex, ST interval, QT interval, and T wave. And then remember where each electrode is placed. Remember that leads do not equal electrodes. And then remember the 2 ways to calculate rate that I've been through. There is another way, but I don't think it's useful, so I'm not going to go through it. Does anyone have any final questions? I've kind of tried to answer as I went along, so I don't think I've missed stuff, but I'm happy to carry on. What is the difference between leads and electrodes? Each section looks so different, so I can't compare them to the normal ECG, how to spot abnormalities. So I'll go back and answer the what is the difference between leads and electrodes thing first. So that's right at the beginning of my lecture. So the difference between leads and electrodes is that the electrode is the physical, like, little pad thing that you stick onto the person, right? And the lead is the graphical representation of the electrical activity, but that's calculated from using a number of different electrodes. So as I mentioned here, 3 of those leads are quite easy to understand, as they use only the electric potentials recorded by 2, and then the remaining 9 use have sometimes 2 or 3 electrodes combined to find the reference electrode. So that's the difference between electrodes and leads. Each section looks so, I don't really understand this question, so I can't compare them to the normal ECG and how to spot abnormalities. So when the person who does the pathology lecture comes in, hopefully they will also have a normal ECG and then show you how to spot the abnormalities. But they shouldn't look different. Like, every ECG that you see that is supposedly a normal ECG should look somewhat like this one in terms of everything being in normal place. And the way that you tell that, like I said, is to use the 6-question strategy and look through those different things. And like, sometimes things might look different, but then if you like calculate the PR intervals and stuff, and that they're all normal, you can still say it's a normal ECG. Were there any other questions? Can you explain the AVR, etc. leads? Okay, I had to go back to the beginning again for that. There's a lot of clicking, I'm sorry guys. So AVR is, I explained it here. So these 3 leads, for example, AVR, AVL, and AVF are these ones that I mentioned. Sometimes you use 2 or more electrodes to calculate what you call the reference, and then 1 for the exploring. So that's what that is. Do they produce the triangle that you mentioned? No. So the triangle is using the limb leads. So that's kind of separate. Can you go over the placements of where they are on the heart again? As in where they are on the heart, or where they go on the chest? So the chest lead placement. Okay, I'm just going to assume you mean the chest lead placement, but that's this slide. I'm sure you'll have access to the slides later as well if you want to check, but this is from Geeky Medics, and they also have a video of how to do an ECG, so watch that if you're confused about where the chest electrodes should go. Are there any more questions? Okay, I'm just gonna go to the feedback link and leave it up for you guys now. Great, thank you so much for coming, and if you could please fill out the feedback, that would be really useful, both for me and for Becoming a Doctor, to inform their future tutorials. Is there anything else that you wanted to say, Hinal or anyone from Becoming a Doctor? Thank you,
No,
guys.
that was
Bye.
all.